Welcome, everyone. This is Dr. John Martin, Chief Medical Officer of Butterfly Network, and I'd like to welcome all of you this evening to another of our educational programs. This is a very interesting one this evening because we're going to go back to something that we typically have as part of our education in the real world when we're in the middle of our residency programs and academic institutions and regular hospital time, where we weekly go over QA, the quality assurance programs in our institutions, to make sure that we're actually doing a good job. I have with me tonight Mike Stone and Grace Wanjiku, who is here today to be the main participants. And my role in all of this is going to be, as I like to say, the chief kibitzer. In my training, Chiefs Conference is what we called it, was our main QA venue. And we got asked all kinds of miserable questions. And when I was a resident and a fellow, it was the weekly skewering by the attendings. When I became attending, it became my favorite thing to do because I was on the other side of the fence. I think this is going to be a much kinder and gentler program, but the design of this is really to go over the key things that we see in lung ultrasound and serve as an educational opportunity for all of us to look at those nuanced things. We don't have the opportunity to be with one another inside a hospital and do this, so we thought we'd bring the hospital to you and give Mike and Grace the chance to actually perform for us a quality assurance evening program. And so I'll turn it over to you, Mike, to take the ball and run with it.
Thanks, John, and thanks everybody for joining, and especially thanks, Grace, for taking the time to meet with us. I know life in and out of the emergency department is even crazier than usual, and we really appreciate your time being here.
Maybe Grace could tell us a little bit about herself and where she's from. You know, I know many of us in the ultrasound world know her very, very well, but there may be some out there that don't. So Grace, why don't you give people some quick background and find out how you volunteered to be the sacrificial lamb here to Mike's questions today.
Oh, hi, everyone. My name is Grace Wanjiku. I am an emergency medicine physician. I'm currently practicing in Rhode Island, so I work at two of our hospitals here. I'm also employed by Brown University, and within Brown University, I am in the Global Emergency Medicine Division. And so I am particularly interested in point of care ultrasound, but how I came into it is that I practice internationally as well. So I am originally from Kenya, and I have been involved in trying to make point of care ultrasound happen there, especially in rural areas, in very low resource places, because I think that this is where this technology really can make a significant impact where there isn't much else. And so that's my particular area of interest. So I'm a global emergency medicine practitioner. I do a lot of teaching internationally, and I am a lover of ultrasound, obviously, point of care ultrasound. Yes.
Thank you.
My goal is really for this, it's going to be casual, conversational. Ultimately, what I'd love for people to leave with after this webinar is a sense of how to tell whether a lung ultrasound image is a good image. Is it interpretable? Is it a quality image? How to adjust the image that you're obtaining if you're actually out there scanning to make it better, to recognize the common patterns that we see. So what does a normal lung look like? What does a pleural effusion look like? What does a pneumothorax look like? What do inflammatory pneumonias look like? What does COVID look like in most patients? And then where are the limitations? You know, can you look at a scan and say this is definitely pulmonary edema versus this is definitely a lung contusion, or this is COVID? There's a lot of nuance in that, and we want to get into some of that. And then ultimately to leave with a framework for interpretation. Anybody who's a physician or a healthcare provider was trained at some point in how to interpret an X-ray and have a very sort of systematic way of going through. And I think Grace has a wonderful way of doing this, and she's going to be highlighting that. I'm going to be driving the mouse to kind of point things out as Grace is talking. And let's just get started. We'll launch right in. We're going to start off with a normal lung ultrasound. So why don't you just walk us through what you're seeing on here, and I'll drive the educational arrow for you.
Okay, so what I can see here is that we are on the lung preset and imaging the lung. And how we know we are looking at the lung is that we have the landmarks that we need. So we have a rib on one edge and the shadow, and then we have another rib on the other end with a rib shadow. And in between those two ribs, is the main area of interest, which is the hyperechoic pleural line that we're pointing at there. So that's where we're going to be focusing our efforts. And what we can see is that as the patient breathes, the line is moving back and forth. So that is what is commonly referred to as lung sliding. But also more than that, we see that there is a normal lung artifact pattern known as A-lines. And so this is the reverberation artifact where, like, at equidistant levels, as you go deeper, you're seeing this hyperechoic line kind of replicate itself, which is not a true structure. It's just you know, an artifact, but it's a normal artifact.
Fantastic. So I think I love the way that you framed that. Number one, finding the right preset, which we're going to get to in a second. Number two, your landmarks and your pleural line to make sure what you're looking at is the pleural line. And then these horizontal lines are those A lines, these regularly spaced reverberation artifacts. And I think a couple of things that are sometimes confusing for people, these horizontal lines that are not regularly spaced, those are not A lines. We do see other horizontal reverberation artifacts. It's a small point, but just the ones that are regularly spaced, sort of same distance from the skin to the pleura as the pleura to the first A line, the first A line to the second A line, et cetera. And I think that's a great way to start. So if I saw this, I could say basically at this area of this lung, normal looking lung.
Hey, Mike, as the novice here, because I don't see an aneurysm in the picture yet, so I'm waiting for something I recognize. How does one differentiate what is an A line and what is not an A line in this picture? How would they look at that if you were a novice and didn't get that?
Yeah, so if you just take a step back with your eyes and look at it, the brightest horizontal lines are this one, and this one. And the really noticeable hyperechoic horizontal bright lines, those are the A lines. The other way to tell is the spacing. And what's happening here is the sound beam comes through the skin, bounces off this strong reflector, which is the interface between soft tissue and air. And whether it's pure air, like a pneumothorax, or it's air-filled lung, like a normal lung, it's going to reflect that sound beam back to the skin. And the sound beam basically ping-pongs between the skin and the pleura. And the ultrasound machine, while it's amazing, is also kind of dumb in the sense that if it takes twice as long for the signal to come back, it figures it's twice as far away. And if it takes 3 times as long, it figures it's 3 times as far away. So it'll just continue to place those lines further and further down the screen.
That's great.
Okay, so we talked about presets. Let's talk a little bit about what can go wrong if you're in the wrong preset. So, you know, with this device, we don't need to pick a probe, but in general, for years of teaching academic ultrasound, I always kind of harped on the 3 Ps of patient. So pick the right patient and put the right patient information in for the study. Probe, pick the right probe. So if you have a multi-probe system, you need to pick the right transducer for the right exam. And then preset. And this is why it's important. And you know, here we're labeled it's small up here, but I put in which presets we're using. So what do you think about this image, Grace, in a cardiac preset?
Yeah, so I think first of all, it's really hard to see your landmarks, just because I feel like for me, that's the first thing I want to look at to make sure that I'm in the right place, I'm looking at the right thing. So it's hard to pick up your landmarks here. And also, I think that, having done a lot of this, you can tell that I think there's a pleural line that you can see there and it's sliding, but the image itself is overgained. So it's very bright. There's just a lot of lines. It's hard to be able to look at it and see your usual, the artifacts that you're used to looking at. So you know that you're in the right place and you're looking at the right things.
And then if we move to a soft tissue preset.
Yeah. So I would say, this one, I can see that there's the rib shadows. I can see the pleural line here. But once again, sometimes depending on how well that is sliding, you might not be able to tell. And then it's also, the depth is not there because you really want to go deep enough to be able to see the reverberations. And so, I can see the lung sliding here from, looking at this a lot, but I just don't think that this image is optimized for everything we want to be able to see.
100% agree. I think we can tell there's lung sliding, but you can tell that it's not really temporally optimized to this image. It's got nice spatial resolution. You can see the pectoralis really well and the fascia because we're in a soft tissue musculoskeletal preset, but you don't really see the artifact analysis as well as we'd want. We'll move through the other ones real quickly. Abdominal preset. This one I think is almost uninterpretable. And then in the probe's in the same place on the same patient for all of these examples.
Yeah.
And then here you can just get a sense that this is back to the image you just kind of covered. And if I can be you for a second, rib and shadow, pleural line, A lines.
Yes.
And we know that we're kind of optimized. So pick the right preset. Okay. A couple of more image optimization tips, and then we'll get into some pathology. If I had to pick the thing that people do the most frequently that's incorrect for lung ultrasound, it's not about where they put the probe on the body, but it's about the horizontal orientation of the probe. So when I say that, I'm going to mime this on, can you still see my video, John and Grace?
Yes.
So, you know, if this were my probe and I'm on my chest, it's this movement, left and right. That's called fanning. And if you don't end up exactly perpendicular to the lung, these artifacts can be hard to see. So this is just an example. You see ribs and you see shadows and you see pleura, but as you fan, you're not really seeing any A lines until you get exactly perpendicular to the pleural line. So here we've got A lines. But if we just back up a little bit, you've got a pleura, but no A lines there. And I don't know, Grace, if you have any tips for new scanners on sort of how to optimize that aspect of the exam.
Yeah, I would say that, you know, sometimes with a lot of teaching, I remember also when I started learning is that I thought that, you know, I just need to be perpendicular to the skin, to the, you know, to the patient's chest, and that's enough. But, you know, that you have to aim to be perpendicular to the pleural line itself. And so, you know, I think going through the motions that you said, trying to tilt, to rock the probe until the pleural line is really as close to the, you know, to the top of the image as you can get it, to make sure that you're being perpendicular to it.
I think that's a fantastic point, and that's something I really like to use as a teaching point. Is the pleura is down here right now.
Yeah.
As we get a worsened image, you're going to see it right now start to drop down even further on the screen,
Yeah.
right here. And then as you go in the right direction, it's coming up towards the top of the screen.
Top of the image,
You'll never get it higher than perfect. So as it goes up towards the top, the highest you can get it is that true perpendicular image to the pleura, because the shortest distance is going to be a straight line, right? So it's nice and high up on the screen. Fantastic. John, any other tips that you have for optimizing the pleural line?
No, I think that the fanning and rocking were the key two things for me that you have taught me that have served me very, very well. And I tried to take a very, if you will, geometric approach. Say, okay, see, it's perpendicular to the chest. That must be perfect. And I found myself early in the game going, well, why isn't this right? Then you taught me the rocking, said, oh, okay, now I get it. And I think once you get to those two tips, I think you end up having a pretty reproducible image. And it can be strange sometimes where that position actually is optimal, sometimes less than what you thought, different than what you thought it should be.
100%. And this is so that first one I would call fanning, that left and right optimization to bring the pleural line up. And then the other main intervention or probe manipulation is heel toeing the probe, sort of, again, if I go back to my phone probe, this direction with the probe, so that you're getting the pleural line to go horizontally across the screen. So that's pretty optimal. And then as we intentionally kind of mess this up by heel toeing, you'll see it takes on this diagonal, or if we go the other way, a diagonal this way. So when you're starting off with scanning, to make sure you're getting a good image and you feel like it's a good interpretable image, right preset, make sure the pleural line is horizontal on the screen, and make sure that it's as high up on the screen as you can get it by tilting back and forth. We can go into gain and depth real quickly, because I do think those are important, and then we'll get into some pathology. I think of gain as just the brightness on the screen. So what do you think, Grace? Good image?
It's too bright, I think.
I agree. So we kind of lose the resolution on the pleural line. Everything is kind of washed out.
And this one is too dark. We can't really see we can't interpret this.
Yep.
We can see what we need to see.
Where is it, Mike? Mike, where is it?
And so this is like Goldilocks, right? We try and find, what's just right. So that's a good example of going through sort of overgained, undergained. Depth is a little bit different for lung than it is for a lot of other things, I think, because if your main question clinically is there lung sliding? I'm worried, let's say, about a pneumothorax. You might want to decrease your depth. And, you know, here's an example. We're in a lung preset. We can really see a lot of movement at the pleural line because we've got such shallow depth. But enough depth to look for things like B lines or consolidations or effusions. You know, probably not quite enough there.
Yeah.
And then I think, you know, getting into a better depth setting there if we're looking for things like A lines or B lines. All right, let's look at some other pathology and some other findings here. So here's an exam where we're moving from one inner space to the next inner space on the same patient on the same side. We're just sliding the probe down. And if it's moving too fast, I can play another clip. Grace, if you feel like you've got this one, I'll let you get to it and I'll try and follow with you.
Okay. So basically what I see is that, you know, I'm seeing our landmarks, rib, I'm looking at the pleural line and just focusing on that as my area of interest. So in the first space, I could see sliding, but in the second space here, I cannot convince myself that there's sliding there, right there on that pleural line.
Fantastic, I agree. So sliding in that space, and then that second space right there doesn't appear to move.
Yeah.
Okay, so what does that raise your suspicion for?
For pneumothorax.
All right. And then what can we do to take a closer look if we're worried there's a pneumothorax?
If you're, you know, you can definitely reduce your depth to really bring your area of interest into focus to see whether you have sliding or not. And
so here we've reduced our depth.
Yes.
And we've also turned the probe horizontally to the pleura so that we lose our ribs, but we get this sort of broad swath of pleura to look at.
Yeah. And basically what I can see here is that there's a part where you see lung sliding, and then there's another area where there's no lung sliding, and there's that area where the sliding comes in and out. And that looks like a lung point, which is very specific for pneumothorax.
This was an example of a traumatic blunt pneumothorax. And, you know, absence of sliding in the right clinical scenario certainly raises our suspicion for pneumothorax, but I think it's important, and I know you talk about this too, Grace, that the absence of sliding by itself doesn't confirm a pneumothorax. You can have absent sliding because you have a dense lung consolidation. You can have absent sliding because you've had a prior procedure like a pleurodesis on that side or a partial pneumonectomy. Yeah. You can have absent sliding because you had an overeager intubation and somebody main stemmed the endotracheal tube, but now there's not really good sliding on the left. And there are subtle ways to sort those out from each other. But ultimately, if you do see a lung point where you have sliding adjacent to no sliding in the same inner space, it's highly suggestive of pneumothorax. And just conceptually, what you're doing is you're putting a probe right on the part where that pneumothorax starts as compared to the inflated lung, and you're seeing that interface.
And I think the reason I bring this up a little bit tongue-in-cheek about the line, though, is, you know, classically we put a line in, wait for a chest X-ray. You may have a patient, for instance, that complains of chest pain in between, or gets hypotensive all of a sudden. You know, don't wait for the chest X-ray. Pull the probe out of your pocket and at least look. You can get a quick answer to that question. It may not be perfect, but you'll certainly feel a heck of a lot better that it may be something else, and you can start moving your decision making to another area. Because a big pneumo that would make somebody, for instance, hypotensive, you should see.
Right.
I agree with that. I find that lung ultrasound for pneumothorax probably prevents the unnecessary decompression of a lung more than it leads to the decompression of an indicated pneumothorax. Mm-hmm. More often than not, we're worried about patient, and for sure, there, you know, near arrest or blunt traumatic arrest. If you want to just put in 2 chest tubes or finger thoracostomies while you're resuscitating the patient, that's completely your call, and there's plenty of cases where that's indicated. But in somebody who's, you know, injured, has some chest pain, paramedics in the back of a noisy ambulance feel like maybe the breath sounds are decreased on one side. Being able to look and see good lung sliding in the front anteriorly on both sides in a patient, I've seen that definitely prevent unnecessary needling or procedures.
Yeah, it's big for patient safety, let's say. Yeah,
absolutely. So we're gonna I think we're going to try and do a poll. We're going to see if this works or not, and our support folks can tell us whether or not it's going to. But we'll get the image up as if it would. And the question here is, which right side or left side image looks like there's absent lung sliding. And we're starting easy, right? This hopefully after what we've gone through, this will be a relatively straightforward question. So we've got left side image here, right side image here, and which one looks like there's no lung sliding? We'll play again here, and I'll put that on loop so it'll keep playing. And we'll give people a couple of minutes to select. I'm going to put my answer in as well, just because I want to be participating with everybody else. Oh, it says host and panelists can't vote, so I can't vote. Never mind.
Gotta have that sound effect now.
Yeah, it's because it's rigged. If I know the answer. All right, and I don't know, John, if you're in touch with Chris or our other admin folks, when we should stop polling, but. If people are done voting, let's close the poll. There we go. So 83% of people with 5 minutes of instruction are able to tell us that there's no sliding on the right side. So well done. On the left side here, we've got rib, pleural line with some sliding, A lines. And over here, we've got faint rib. You're only seeing part of it. Rib here. Just an interesting fact, if you ever wonder why sometimes the rib is just shadow and you don't see pleura underneath, but then sometimes you see rib and you do see pleura under the rib. That just means you're closer to the sternum and you're looking through the cartilaginous portion of the rib, so you're able to see the pleura underneath. But there's pleural line, and even though the chest wall moves, because this person is still, in this case, kind of desperately trying to get a good breath, there's no organized leftward, rightward sliding on this side. So notice we didn't ask, is there a pneumothorax, because we can't make that call off of just absent sliding, but in a trauma context, this would make me highly suspicious.
Mike, a good question from the audience as you move to the next one. Where do you start first scanning? Which part of the lungs? I mean, obviously you can't tell from these images where you are. So where do you guys start? What's your protocol?
Grace, you want to take us? So let me parse that into two questions for Grace. Grace, question number one, yes. Do you always start in the same place regardless of what your clinical suspicion is? So like, let's say you have a trauma patient versus a patient with a fever and cough. Do you do the same scan on everybody?
I always find myself starting anteriorly, like basically like right here, just that's kind of where I go because it's the least dependent area, and that's where I would expect that air to rise if there was. So I find myself starting there, but then basically you keep, walking down, the rib spaces, and you keep looking, and then you can go laterally as well. And then, if the patient is able to sit up, you can look in the back. But I always find myself starting basically right here.
Yeah, so I would agree for trauma in particular, I will start, our trauma patients generally start off supine or near supine. Yes. Air is going to rise. Typically anywhere from the 2nd to 5th intercostal space tends to be the furthest from the ground by gravity. So that's where I'll start my exam as well for trauma. In patients with fever and cough, I'll often start my exams posteriorly or posterior laterally, and especially now, when most of the fever and cough that we're seeing is highly suspicious or confirmed COVID, we know that it preferentially affects the lower lobes and the posterior lobes. And it also lets me stand behind the patient if they're able to sit up and not get coughed directly in my direction as I'm scanning them. So it's a really good question. I think there's probably a lot of variability in how we do it. Here we have another clip. I'm just gonna go ahead and loop it so that it'll keep playing. And this is an image from the posterior lateral aspect of the chest. And we're going to go ahead, and the question is going to be which image, right or left, demonstrates a pleural effusion. If anything, this is one of those things where ultrasound is probably more sensitive than it needs to be. Ultrasound can detect pleural effusions like as small as 5 to 10 mLs. So I don't know if this is your experience, Grace, but when I first started ultrasounding and looking down in the lower areas, I'd find these effusions that looked pretty substantial. And then I'd get a chest x-ray and it would look like blunting of the angle or nothing major. Have you found that too?
Yeah. Oh yeah, so, yeah, all the time. You miss them so much. Yep. It's just one of my favorite things to do because it's usually.
Okay, so we've got 88% of people feel like there's an effusion on the right, and I would agree with that 100%. You want to walk us through the left image first, Grace, and then we'll take a look at the right after that?
Okay, so I can see that here you're using the abdominal preset, and I see a solid organ here that looks like the liver. I see this bright hypoechoic line that is the diaphragm here that inserts right here, and basically going superiorly and towards the patient's head here. This would be the pleural space, and I don't see any fluid there. Like I don't see any hypoechoic fluid above that diaphragm. So this looks like a normal look at the pleural space there.
Totally agree. One thing that people sometimes like to comment on as well is, you see this hyperechoic line here and another one here and some shadowing. These are the vertebrae deep to the liver. And you see that this vertebral column just kind of ends abruptly as you get to the diaphragm. And that's because air is scattering the ultrasound as it's trying to get towards the spinal column. So we kind of lose the spine at the diaphragm. That's a normal finding.
Yes.
And then walk us through this side.
So this side, basically, you're still using the abdominal preset here. You still see the solid organ there, the liver. You see the diaphragm there, but above the diaphragm, there's this hypoechoic area. This is pleural fluid, and there's also a part of lung that could be consolidated lung or just atelectasis, and also more posteriorly, like Mike was saying, is that now we can see the vertebral bodies continuing beyond the diaphragm into the pleural space, where usually we couldn't see them before. And that's because this fluid, like ultrasound, has an easier time going through the pleural fluid than going through lung parenchyma. So now we can see the spine where we ordinarily wouldn't. And this is what is called the spine sign, and it's an abnormal finding when there's an effusion.
Absolutely agree. One of the other things is kind of interesting. So two things I want to point out before we move off of pleural effusion. One, abdominal preset I actually think is the right preset for this. And the reason is you're really looking at the interface of the abdominal organs and the diaphragm and the lower portion, the costophrenic angle or the supradiaphragmatic space. And I just find that I get a better resolution with an abdominal preset for this than a lung preset. I like the lung preset for artifact analysis, A lines, B lines, small subpleural consolidations, pleural sliding. But when I'm looking for effusion, I really like to have an abdominal preset, and I think it gets you a cleaner image. John has a question. I can see because his hand's raised.
That's right. I'm being polite now. How about that? Write that down. So a couple of quick questions on this. First of which is, how do you position the probe for this view? Where is the probe?
Yeah, so again, we'll transition to our, so number one, I'd refer you to the free educational content that's on the Butterfly education platform that has some narrated videos showing you how to get these images. The other is if we just,
Mike,
if we're putting you, oh yeah, well, you don't want that then. So you're here, you're basically like coming out with the probe just to sort of almost where you would do a right upper quadrant fast exam. So kind of mid-axillary line, maybe posterior axillary line, and then just above where closer to the head than you would be looking for the liver-kidney interface. You're just maybe sliding up one or two interspaces from there.
And you're holding the probe vertical, not horizontal.
Yeah, so indicator towards the head.
Yep. And do you have a formula in your head to calculate the volume of fluid as you're looking at it? Is there a way in which you do that?
So there are formulas that have looked at sort of maximum depth, maximum height, and a little bit of casual arithmetic to estimate the volume of pleural fluid. I can honestly say I've never used any of those. I've read about them. I know they exist, but for me, it's a clinical concern. For me, if you have effusion like this on the right, it's at least moderate. A small stripe above the diaphragm is going to be a small effusion, and then if I'm seeing an effusion anteriorly, which will show an example, I can do it while we're talking. That tells me you're looking at a pretty sizable pleural effusion. But yes, you can. There are formulas out there. I would refer you to Dr. Google if you wanted to calculate the size of a pleural effusion.
Before you move on, the last one is, how do you tell if it's free flowing? Do you guys rock the patient or anything like that to tell whether it's free flowing or loculated?
That's a really cool question. For me, I don't turn the patient during the exam to get information about whether it's free flowing. loculated pleural effusions will tend to have internal septae. So you'll see these hyperechoic lines running through it, and it'll look very complex. Pure anechoic fluid like that is almost always transudative. And there is some interesting literature out there on just the ultrasound characteristics being able to guide you towards an exudative or transudative effusion. Just before I forget to do it, this is what it looks like when you have an effusion anteriorly. So we're in a lung preset, rib and shadow, and we can see this anechoic space just deep to where the visceral pleura lies, and that's an anterior pleural effusion. So by the time you're seeing that up in the anterior lung windows, you know that effusion's gone pretty high and you've got a sizable effusion that you're dealing with. Okay, let's go and look at some timely stuff. So Grace, walk me through what we're seeing in this one.
Okay. So for this one, lung preset, I think we have what I think is a, rib shadow. I see the pleural line, very hyperechoic. It looks thick, it looks irregular to me. It is sliding back and forth though, but it's very thick. And then coming off of it are these very large, torch-like lines that are going through all the way to the end of the field that are known as B lines, or come to known as B lines, and they are abnormal. And also in between, we are seeing that there are some parts which do not have B lines in them. So I see the A lines, the normal horizontal artifact there, and then this big, B line pattern.
Okay, so, and B lines traditionally have a number of characteristics associated with them. They start at the pleural line. They're hyperechoic. They're bright. They're vertically oriented. They move with respiration. They go all the way to the bottom of the screen, and they erase the normal A-line pattern. And I think that these satisfy all of those criteria, right? We're seeing that all of those things present. What's interesting in this case is the sort of spared areas of A-lines that we're seeing on either side of these lesions, and the irregularity and sort of discontinuity of the pleura, where you have these little divots in the pleura, or this irregular shape to the pleura. One of the things, this is a patient with confirmed COVID pneumonia, just no spoilers here. We're not trying to fool anybody or hide the diagnosis. One of the things that I think is really interesting is, we've seen this described as a thickened pleura, and there's a whole lot of semantic discussion going on in the medical field right now about whether we should call it pleural thickening, because it's really that the artifact makes the pleura thickened, not that the pleura itself is thickened. However you want to conceptualize that, I think is fine. What I like to focus on with these, not only the spared areas, but this irregular looking pleura, how does that compare to what we're used to seeing for B lines? So, 6 months ago, if I said, Grace, I've got a patient who comes in, they've got B lines in all their lung fields, no thinking, no other information, what are you thinking the diagnosis is?
A lot of times it's pulmonary edema. We have a lot of people who come in with CHF exacerbation. And so everywhere we look, we see B lines everywhere. But the pleural line is usually still remains very sharp, very bright. And so for COVID-19, I think this is a bit of a different finding in terms of the pleural line just looking very thick, discontinuous, and then the B lines being patchy. So you see them in some places and not see them in other places. Whereas for pulmonary edema, especially in people who are like really sick, very fluoridated, ill, they have the B lines everywhere. There's no strip lesions.
I think there's a number, Mike, of how many B lines is pathological. Are they all pathological? And do you see different quality to the B lines between, interstitial lung disease, congestive heart failure, or maybe pneumonia in this situation?
Yeah, so I think all good questions. The B lines are B lines. Just because the definition is so strict that if it starts at the pleural line, it's hyperechoic, it goes off the screen, it moves with respiration, it doesn't fade, it erases A lines, that's a B line. I think Grace's point about distribution of B lines is very interesting from a CHF perspective and pulmonary edema versus infectious perspective. If you asked me 6 months ago, you see B lines all over the place. The things that pop to mind are pulmonary edema, in which case they tend to be more present in the lower lung fields. They're gravitational. You'll often find small pleural effusions in patients with pulmonary edema, which you don't typically find in COVID patients. interstitial lung disease or interstitial fibrosis can cause B-lines everywhere, in which case there is often an irregular pleura as well. Diffuse pneumonitis, like a viral pneumonitis like COVID, you'll often see scattered B-lines all over the lung fields as well. Really focal B-lines make me think about a pulmonary contusion or a pneumonia. But just to and then to answer that question about how many B-lines, I can't remember what year it was. I want to say it was around 2010, the international consensus on lung ultrasound with a bunch of lung experts. 3 or more B-lines in an area gives you is pathologic. So if you're self-scanning or you're looking at a patient, you find an isolated B-line somewhere, just 1 B-line, 2 B-lines, I'd probably ignore that as being clinically significant. You need to see a bunch of them in the place you're looking to call it pathologic. But you can see this could be hard to differentiate. I mean, this is a patient from way before COVID, who, we're not really covering cardiac today, but I don't think you need to be an expert to tell that left ventricle does not look like it's doing very well. And this person has a dilated, severe myopathic left ventricle, so systolic heart failure, and came in with a very classic heart failure presentation. And yeah, there's B-lines. As they breathe, you do see some A-lines, although the B-lines do look like they come in and out of the entire area. You're not really seeing sparing on both sides. I don't really see a whole lot of discontinuity or thickening or excuse me, irregularity to the pleural line. But I think this can be tough. And I think that if you're really going to make a case that B-lines are you're going to be able to differentiate the B-lines from COVID from the B-lines from pulmonary edema due to heart failure, I think you need to be a very experienced lung sonographer to make that call or to feel like you can make that call. I do think there are features that I look at and that Grace looks at, and people who've done QA for years and have done a lot of lung ultrasound, it just appears different in the same way that an experienced cardiologist will have a different read on a subtle EKG finding as opposed to a second-year resident, right? It's just, some of it's just seeing a lot. But some of these features do definitely lean me one way or the other. But if we're gonna quiz ourselves and see how hard it is, let's take a look at one other image. And one of these frames is a patient with proven COVID, and one of these frames is a patient with pulmonary contusion from trauma. And I'm going to go ahead and loop this image. And why don't we put a poll up? Which frame is COVID? So left or right? Which one do you think is coming from COVID, and which one do you think is coming from a pulmonary contusion in a trauma patient? And while this is up and people are thinking about it, this is really challenging, because in places where you're seeing, I'm in Oregon, we're seeing COVID, but we're not seeing it to the extent that our colleagues and friends in New York and New Jersey and Michigan and some of the other places are seeing it, where everyone in the emergency department in my buddy's ER in New York has COVID. It doesn't matter if you're there for a shoulder dislocation or you're there because you tripped on the sidewalk. You have findings on lung imaging, and everyone has it. So a pulmonary contusion, I'm not sure how you sort out who has a pulmonary contusion in that emergency department when you come in with lung findings. But just from a pure academic and image interpretation standpoint, let's see what people thought about this. So people thought COVID was right and pulmonary contusion was left. And I did this to be a little bit tricky and to give you a flavor of what it's like to be put on the spot during QA, but it's anonymous, so nobody has to feel bad about their answers. The left one is a patient with proven COVID, and the right one is a patient with a pulmonary contusion. And it's really meant to drive home the point that we like to, in the lung world, talk a lot about the subtleties and how you can pick out one B-line diagnosis from another B-line diagnosis. And you need to be very experienced to do it. So what about this makes me think that this, if I had to guess and I didn't already know the answer, the pleural line's really thin. There isn't a whole lot of irregularity, although it's really regular, although there is this one little divot right there that makes you wonder if it's irregular. It's through the entire lung space. Okay. This side, there is more of a subpleural consolidation, and it is a little bit more focal. I would not feel comfortable. I know these images because I scanned these patients. I would not feel comfortable being able to tell you which one was which either. So if you picked the right as COVID, you're in good company. I'm pretty sure I would have done the same thing. And
did this one right, Grace? Did you get this one right?
I without knowing the history, I think I would have picked the right image as well.
Yeah, because I flunked this test, Mike. And I guess the other question I have for you is, do you have a measurement of thickness, or is that you guys just have experienced eyeballs, what's thick and what's not?
Yeah, so again, I'm going to try, just for the lung semantics in the world out there, to avoid using thickness. I know I slip up and use it from time to time as well. It's really the irregularity. It's the fact that you're seeing gaps in the pleura, and it's not a smooth looking linear pleura. There's one interesting study that was done in 2018, so pretty recent, where some folks looked at M mode and lung imaging to try and differentiate. This was pre-COVID, obviously 2018, but to differentiate cardiogenic pulmonary edema from inflammatory B lines. And I'll see if I can share this, and I'm not sure if I can. It doesn't look like it wants to let me, and that's fine. We don't need to get into, well, hold on, I may just need to unhide that image, and we'll see.
While you're playing, Mike, you want to tell us the difference between B lines and comet tails? Are they the same thing, different?
Nothing would give me greater pleasure than to talk about B lines and comet tails. All B lines are comet tails. But not all comet tails are B lines. So a comet tail artifact is a vertical hyperechoic artifact with a rapidly repeating reverberation artifact. You can get comet tail artifacts off of a bullet or a piece of metal in the tissue, or anyone who's ever placed a central line. That ring down artifact you get off the needle as you're putting the needle in, that's a comet tail artifact. There's also what Lichtenstein, who's really, one of the if not one of the fathers of lung ultrasound, coined Z lines for being insignificant, which is why they have the Z. They start at the pleural line, they go down just a tiny bit and then fade, and they move with respiration, and they don't really have any clinical significance. So comet tails can be useful in the sense that if you see that artifact coming off the pleura, there's no pneumothorax at that location where you're looking, but it doesn't really give you a whole lot more information, and not all comet tails are B lines. I don't know if that clears it up. It's sometimes the nomenclature around lung feels like you're learning an entirely new language. So if it's confusing, you're in good company.
Great. Did he get that right?
Sorry.
What's that?
Did he get that right, Grace? I just want to make sure that you're checking on his answers. You can flip this stuff past me, and I'm not going to know the difference. He do the QA answers, okay? So that he's not sending out bad information. I don't trust him.
This is Mike Stone we're talking about here. He's my professor.
Grace is getting paid a lot of money to say that.
But see, Mike would say something like this to see if I could pick it up, just to try to pull my leg to see if I could recognize it.
No, I agree 100%. I think that you can have comet tails that are not B lines, because by convention, like you said, the B line, it comes off of the pleural line, but then it's like goes all the way through to the end of the field. And some people call them like lung rockets. But sometimes you can just have like a little, comet tail that just comes off of the pleura, doesn't go anywhere, doesn't go all the way through, and it goes, it moves with the pleural line, and that can be a normal finding, or a non-significant. So I agree 100%. Yes.
Just QA the QAer.
All right, I made it. So not going to go into detail into this study, but use of M mode to differentiate the cause of B lines. Interesting study from Chest from 2018, in case anybody wants to take a look. And what they did is they looked at non-cardiogenic pulmonary inflammation versus cardiogenic, and this fragmented pleural line that you're seeing on M mode you're really seeing the same thing on the B mode image above it. It's that discontinuity and that breakage of lack of that smooth linear appearance to the pleura. And they found that it performed reasonably well when they looked at this non-cardiogenic pulmonary edema fragmented pleural line in almost 90% versus only about 7% of patients with cardiogenic pulmonary edema. So there probably is a signal here. There probably are some things we can learn. At the moment, I don't think it's quite ready for prime time. Pretty small studies, single center. And if you're looking and you're still kind of confused as to whether it's a COVID lung or a pulmonary contusion or pulmonary edema, I think that's okay. I think that a lot of this is going to be clinical context. We have to remember that point of care ultrasound is one more tool for us to use. It is not going to be the thing that, you know, somebody who doesn't have good diagnostic ability or clinical sense who's holding an ultrasound doesn't magically become somebody with good clinical sense and good diagnostic skills. It's an extra tool for us to use, and we need to put it in the context of everything else that we're seeing. So John, any other questions before we want to launch into the next one here?
No, I think I've got some. I want to see some good junk within the lungs itself.
Okay, well, you came at the right time. So we're gonna play one more clip here. We'll have people vote, and then I'm gonna have Grace walk us through this. So here are the images we're looking at. I'll tell you, one of these patients has a, let me go ahead and get loop on again. I'll tell you, one of these patients has a lobar consolidation from Streptococcus pneumoniae, so kind of classic strep pneumonia. And one of these patients has a viral subpleural consolidation in a patient with COVID. So why don't we put the poll up, and the question will be, which frame demonstrates the lobar consolidation, the sort of run-of-the-mill community-acquired pneumonia patient? So right or left shows the pneumonia patient, not the COVID patient. And while people are voting, noting that patients with COVID, go ahead, Grace. Oh, that's okay. Patients with COVID can develop bacterial infection, just like patients with influenza can develop bacterial infection on top of their underlying viral process. So obviously we're not saying that those things have to be exclusive, but there is a characteristic appearance to one versus the other. All right, so 82% went with the right side as being a lobar consolidation, and that's absolutely correct. Grace, why don't you walk us through the right image first?
Okay, so on this image, basically, I do not see the preset. I think it's an abdominal preset here, but what I can see is that we're looking at the lung, but we're seeing less of what we're used to lung looking like. We're just seeing areas that look like tissue here. We're also seeing these bright specks here, which have been referred to as air bronchograms. And I think there's also some fluid around this area here.
Yeah, so maybe a small amount of fluid up here.
Fluid there.
And then these are the air bronchograms, these linear kind of worm-like structures that we're seeing through the lung.
Yeah, and then the lung looks more like flesh-like now. It looks more like a solid organ in places, and it's darker than what we're used to lung looking like. So this is what the consolidation looks like.
Okay, and then on the left here, walk us through this one.
Okay, so we can see part of the pleural line. It is discontinuous in places, and there's one area here where there's like an hypoechoic area compared to the rest of it, which it looks like, I think it's a consolidation. And then, you know, we have a rib shadow, and we have some B lines. Absolutely. So, you know, these sort of subpleural consolidations, it's hard to really know, I think, where your threshold is for, is this a small subpleural consolidation, or are we getting into a real pneumonia? You know, this one makes it obvious. There's a pretty giant lobar consolidation. For me, you know, things under 1 centimeter in size, and we've got some centimeter markers out here, I tend to call subpleural consolidations. As they get a bit bigger, I start to think about whether there's more of a true consolidation present. I don't think that there's strong evidence to guide us one way or the other on that particular definition. So I want to clarify, I'm kind of speaking on opinion there.
What I have learned thus far from experts and from you, Mike, is that for instance, that case where there was a large pleural effusion, that is unlikely to be COVID. We've not seen that to be typically the case with COVID around the globe. But there are some features. What would you say are those features that are typical of COVID? If you saw that pattern clustered together, your index of suspicion goes way up. What would those be?
Grace, you want to take a stab?
Sure. So I think that what we're learning so far from our colleagues who've done this more is that the the irregular pleural line, and then B lines with skip lesions are very typical. And then the subpleural consolidations, that like the one Mike Stone pointed out, that those are the predominant patterns that they are seeing, and they are less likely to have pleural effusions, like you said.
Yeah, I agree with that. I think irregular, fragmented, ratty looking pleural line, just lumpy bumpy, as my friend and former colleague Vicki Noble would call it, a lumpy bumpy pleura. Spared areas, which some people also call skip lesions. So this idea of patchy involvement of the lung and not confluent involvement of multiple interspaces at a time. The other thing is, you know, if you look at CT imaging of patients with COVID-19, the findings tend to be peripheral, which makes them accessible to ultrasound, which is great. And I remember 3 months ago, maybe 2 months ago, seeing those first CT images and thinking, I bet our colleagues in China and Italy are going to start using lung ultrasound for this, because if the disease process doesn't reach the pleura, you can't really see it with lung ultrasound. If you have sort of a classic round pneumonia or hilar pneumonia and the lung around the periphery of that's touching the chest wall is normal, that air just stops the sound wave from penetrating, and you won't see that pathology. It's one of the weaknesses for pneumonia. But with the distribution of COVID around the periphery, it's amenable to lung ultrasound imaging. And I would say everything Grace touched on, the absence of large effusions, the subpleural consolidations, patchy involvement, irregular fragmented pleura, and then the last thing would be distribution. So mostly posterior and posterior lateral, and mostly lower lobe. We don't tend to see as much in the upper lobes, but certainly in severe cases, you can have it everywhere.
So what makes the irregular configuration of the pleura? Because the pleura doesn't go away. Why does it become irregular in these patients? What's the pathology that's involved there?
I think I think the short answer is nobody knows. We don't have, there's still a fair amount of debate as to what anatomic abnormalities and pathologic variations cause some of the artifacts that we see on lung imaging. But I think what we're seeing is the difference in an inflamed pleura versus the difference in a volume overloaded pleura. So someone who has pulmonary edema from heart failure, where there's just more fluid leaking into the interstitium and the alveolar spaces, the pleura is not inflamed, there's just fluid accumulating in the lung, as opposed to an acute inflammatory process with white cell infiltration and inflammatory mediators. I think we're starting to see irregularity and inflammation of the pleura. That would be my guess. We also see that in scarring, though, and in chronic conditions. So people with interstitial lung disease who've had a lot of scarring or sarcoidosis, you can see that same lumpy, bumpy pleural line. So to me, I think of autoimmune infectious conditions causing a fragmented pleura, and something more along the lines of volume overload causing a smooth pleura.
So we've seen a lot of actually discussion around the use of CT. What do you see as the sensitivity of ultrasound versus chest X-ray for pneumonia?
That's a long topic. There's at this point a solid 10, 15 years of literature looking at lung ultrasound for pneumonia. Obviously not 10, 15 years on COVID, but on pneumonia, lung ultrasound performance versus chest radiography performance. And lung ultrasound is at the very least non-inferior. It's as good as chest X-ray for pneumonia in multiple studies and in meta-analyses. The interesting thing about COVID is obviously the data that we have at this point isn't the most rigorous, because everyone's just trying to provide great patient care and do the best they can in a very stressful time. So no criticism on the researchers. One of the things we're seeing from chest radiography studies out of China and Italy is that the sensitivity for COVID pneumonia in chest radiography can be as low as the high 30% up into the 70% range. We're finding that lung sonography is more sensitive than that. I don't have specific numbers to give, but I can tell you that we have colleagues in China and colleagues in Italy who've really borne the burden of the initial waves of this illness, who've transitioned to lung ultrasound predominantly and CT for challenging cases, where there's diagnostic dilemma about whether they maybe also have a pulmonary embolism, or they might have a loculated effusion or a large consolidation. And then chest x-ray has not really had the similar role, in the sense that its initial sensitivity is poor enough that people have shied away from it in multiple settings. I'm sure it's institutional dependent, and there's plenty of places you can look where people are still getting a chest x-ray as an initial screening test.
Have you guys used it, I guess, in your circumstance, obviously in these environment of COVID, how are you dealing with the issue of keeping the probe obviously from infected other people, or in putting in central lines? What are you doing with these handheld devices, both pre and post now COVID? Are you doing anything different in the COVID environment? Cleaning, disinfection, sheaths? What's the way in which you guys are addressing that issue?
You know, in this age, I think sterile technique has become, you know, primary, and, you know, basically trying to, you know, keep your probe as clean as possible. And I think this is where like handhelds really shine, because, you know, you have a smaller machine, you can cover it as much as possible. You can cover your probe with a sheath to keep it clean, and be able to disinfect it right after. And so basically, you know, in my institution, we're not able to use handhelds just because we haven't set up our system to be able to use it. So, you know, you can still bring the cart-based, but then remove everything else other than the just one probe that you need. If you have something that has a touch screen, it's better because you can, you know, use it and then be able to wipe it down right after. So things like that. But I would say that, you know, handhelds in this era are very advantageous in terms of being able to cover it with plastic and being able to cover your probe as well when you're doing this.
Yeah, we have some resources on the butterflynetwork.com/COVID/19 or -19 on disinfection, and some outside resources as well, with some great minds in the community who have been kind of going back and forth on best practices here. My own personal practice is sterile. I don't use a sterile probe sheath for the general exam in a patient who isn't in sort of airborne generating procedure type environment. So somebody who's not on CPAP or BiPAP or high flow nasal cannula or getting intubated, I won't typically put that in a sterile sheath. I'll just disinfect with the approved wipes for a solid 2 minutes after the scan, and disinfect I have a phone that is only for work, that isn't my personal phone, and it just gets disinfected and stays at work. For patients where they're critically ill and you've got a PAPR on, if you have access to a PAPR and you're in the midst of doing, you know, an airborne generating procedure, sterile probe sheath, probe and phone in the sheath while you're still in the room after the gown comes off, but before anything else comes off, dropping that into a basin with a towel at the bottom of the basin, wiping it down for 2 minutes there, sliding it out of the room, getting out of the room and getting the rest of the equipment off, regloving, and then wiping it down again at that point. So that's been my general practice, and I think mirrors the practice of a lot of people who have been doing this particular COVID response longer than I have, whose opinions I respect.
If you guys got a few more minutes, there's a couple here that were interesting to answer if we can hang just a little bit longer. And here's on both ends of the spectrum. Have you seen where any of the image findings on ultrasound have been predictive of who needs to be intubated? And on the flip side of it, on the other end of the spectrum, have you noticed that ultrasound findings are being predictive of people getting better? i.e., do they resolve over time as a good indication that someone is actually emerging out of the COVID crisis, if you will?
I can take that one if you want, Grace. I think that there is no convincing evidence that lung findings will necessarily predict who's going to progress. I can speak to having scanned a family member with COVID who had significant lung findings in a number of areas and improved. I think many of the people on the webinar, and certainly a lot of folks who followed ultrasound in the era of COVID, followed Jale, who was posting his own experience on Twitter, self-scanning day by day, and he had some pretty impressive lung findings and never required hospitalization or supplemental oxygen. So I think that they can be tricky that way. For prognosis, if you look and you really see a clear A-line pattern, it would make me wonder at all if the patient has COVID. And if you look and you see minimal findings, sadly, I think the nature of this disease is that it waxes and wanes and it's unpredictable. and that you could certainly progress pretty rapidly, even with pretty innocuous findings up first. The second half of the question is more optimistic in the sense that a lot of my ICU colleagues have noted that return of A lines tends to predict respiratory resolution and improvement, and that tends to happen very much in real time. We see that in other conditions. We know that lung ultrasound is incredibly dynamic as opposed to chest x-ray, which can lag for days. So work that Andrew Lateplo and Vicky Noble did over a decade ago on dialysis patients with B lines, you would see those B lines resolve during dialysis. So it's very real time, and you see these dynamic changes in the lung. And our intensivist colleagues who do a lot of lung ultrasound are seeing, that they can monitor the effectiveness of some of their maneuvers, whether it's vent changes or recruitment maneuvers or position changes with proning or slow turning of the patient. And that resolution of A lines does tend to predict recovery from a respiratory perspective.
So here's an interesting one, Grace. Can you clarify the difference in COVID subpleural consolidation versus true consolidation in pneumonia? And if subpleural consolidation should just be seen as inflammation rather than really infective changes?
Yeah, I think, I apologize that I didn't really clarify that, but the small subpleural consolidations, it's what Mike was saying, that they're very peripheral. They're right, beneath the pleural line. They're very small. And those, I think, Mike, and you can correct me, is that they are more consistent with inflammation. Those small subpleural consolidations, as opposed to, the large consolidation that we saw mostly, if you're looking in the posterior region, where, the lung itself, there's a large part of the lung that had started to look more tissue-like what people say hepatization, and you had air bronchograms in them, especially if they are mobile air bronchograms, and that is something that has been proven to show consolidation that can happen with a lobar pneumonia. So I didn't really clarify that, but the small subpleural ones, they can just be an inflammatory, something that's coming from inflammation, as opposed to the big lobar pneumonia with air bronchograms in them.
Yeah, I'd agree with that. I think you can see subpleural consolidations in a number of diseases. We sometimes see them with pulmonary emboli. So you can see these small subpleural consolidations with pulmonary emboli, with malignant disease that's infiltrated the pleura. Generally the less than 1 centimeter peripheral subpleural consolidation, Lichtenstein originally would call those C lines. They're not lines, they're consolidations, but just sticking with the ABC nomenclature he was working with. To me, that just leans you more towards an infectious inflammatory syndrome as opposed to a volume overload syndrome. So that's sort of how I think we think about those similarly. And then the dynamic air bronchograms, that big sort of socked in hepatization, that's pretty clear that you've got a pneumonia.
All right, well, we're getting toward the end, and I want to give you guys a chance at the very end. I know, Mike, you've done a lot of teaching modules that exist on the Butterfly Network. I would refer people, some of them have asked, are there other modules there? How should you start and learn how to do these things? What are the starting positions? I think your teaching module is probably the best place to find them. But if each of you could kind of lead with a few pearls for everyone, and make sure that they're the good kind of pearls, not the bad kind of pearls, that would be great. So Grace, why don't you start, and then we'll end it with Mike.
So basically just reviewing the pearls for lung imaging. For me, I would say that, looking at your landmarks, because you really want to make sure that you're in the lung and that you're looking at the right thing. So make sure your landmarks are right. And then for COVID-19, like we said, I think the primary findings they're saying is the irregular pleural line, the B lines that you see with some areas that are spared. So some areas that have the normal A line pattern, and then B lines that go all the way through. And then the small subpleural consolidation, and largely the absence of pleural effusions, I think, is the key to imaging for, if you're looking for COVID.
Fantastic. So you took all my good points, Grace. Go ahead, keep going.
No, it's okay. No more. I'm done.
I would say leaving points would be an image that you've acquired that's of high quality is infinitely easier to appropriately interpret. So practice your image acquisition, because point of care ultrasound is knowing who to do the patient on, getting a good image, interpreting the image correctly, and then applying the results. And those are really integrating those results into your care. Those are really the 4 steps. if you had to, let's take out the first and the last one, because those are really just clinical steps that anybody who's a healthcare provider should be able to do without any ultrasound expertise. I think the ability to obtain a good image trumps the ability to interpret a good image in terms of difficulty and importance. So if you want to learn how to interpret images, watch this webinar again after it's recorded and posted. Go on YouTube or Google or Med Twitter and look for examples of effusion or COVID or pneumothorax or whatever. You'll find tons of free information out there that gives you plenty of chances to practice what you're looking at. Nothing can substitute for taking the probe, putting it on a patient, getting a good image. And the stuff we talked about up front, probe orientation, preset, rocking, fanning, optimizing that image with depth and gain. If you can get that part right, the interpretation is going to flow really easily after that. So just get good images in, good interpretations out. Garbage images in, it's a lot harder to tell what you're looking at.
That's great. Well, I'll leave you with my parole is that the value of lung ultrasound is not going to end with COVID. And I think that for everyone who is using this opportunity to learn ultrasound, you're learning a skill that will serve you very, very well going on. And COVID may be that one time where all of a sudden the rest of the world figures out, hey, lung ultrasound is incredibly useful. And whether you're an emergency physician, a primary care physician, a cardiologist, a vascular surgeon, an anesthesiologist, learning how to do lung ultrasound is a very valuable tool, much more valuable than that stethoscope that people are wearing around their neck. And so take these lessons from these two experts to heart. They've been incredibly helpful. I thank you both for spending the time with us. Thank you, Grace. Keep up the good work. And Mike.
Thank you so much for having me.
The professorial skills remain intact, and we bow between both of you and your experts.
Oh, please.
Someday I would like
Thank
to
you, Grace. Thanks for spending the time with us.
All right, guys. Thanks very much.
All right. Take care, everybody.
All right. Bye-bye.